Hello and welcome to an information session about medical imaging and the professions within that realm. There are a lot of choices that you can do, and a lot of times it can be confusing. What pathway do you get to go to the profession you want to do? Um, there's multiple ways to get there. There's multiple organizations that credential for that. So I'm going to be talking about all that. My name is Rob Cruz. I am a program director at Loma Linda University. I have taught there since last century. I started in 1999, so I have quite a few years of experience delivering content in multiple programs. So we'll be talking about those today. Um, all right, so here we go. We'll just jump right into the medical imaging profession. These are all the modalities that you can specialize in. So you can see right away why this field can be so confusing. We have the X-ray tech, or radiologic technologist, radiation therapist, nuclear medicine tech, ultrasonographer, cardiac electrophysiology specialist, cardiac and cardiac vascular, interventional, also called IR for interventional radiology, cardiac interventional. So the difference between those is cardiac interventional focuses on just the heart, whereas the cardiovascular interventional focuses on everything else. You can be a CT tech, MRI tech, mammography tech, bone density tech, registered radiologist assistant, not to be confused with a radiology assistant, which is a transporter. So the RRA is an advanced specialty of radiography. You can be an echocardiographer. You can go into management, education, PACS administration, which we'll talk about, and you can mix and match all of these. So you are not limited to just one profession. And we'll also talk about the limited technician. All right, so to get into these, there are prerequisites. Each modality, so each imaging type that I talked about uses a different type of camera, basically, and it has different physics behind how it calculates and creates the image. So anatomy and physiology is very important. We are the eyes of medicine. We take a look inside using different modalities, different physics to produce different images with different data. So we have all of those different modalities because each one of those has its own strengths and weaknesses. So one body system might be really good using CT, whereas another one might be better using MRI or ultrasound or any of those other professions that we talked about. It just depends on what we're looking for, why we're looking for it, and what we need to see, what information do we need to glean from the imaging test or interventional procedure. Physics, it's usually intro to physics. It's conceptual. But once you get into the program, you will take a look at how X-rays interact with matter using X-ray physics, how magnets and radio waves work to make your MRI images. You'll take a look at particles, how they interact with the tissue to kill cancer cells, radioisotopes to gather clinical information for those types of physics. And last but not least, ultrasound for sound waves and how those interact with the body tissues to produce an image. So there's quite a few different types of physics that go into it. Of note that I find very interesting is the first Nobel Prize for physics was won in 1905 or presented in 1905, and it was the person who discovered how X-rays work. That's Wilhelm Conrad Röntgen from Germany. He discovered it in 1895 in the early part of November of that year. And the first diagnostic X-ray was taken just a few months later. So it is the oldest imaging profession to look inside the body in a non-invasive way. All right, so English composition, you're going to be required to make notes in patient's chart. So it's good to know how to write concisely. So English 1 and 2 or 101, 102, whatever facility or organization has that labeled, the freshman core, right? Speech is required for some of these professions, some of them aren't. I took speech many years ago because it's important to be able to relay information in a logical way. So you're going to be talking to physicians about your imaging. You're going to be interacting with your patients, families, friends of those patients. So you need to make sure that you know how to do that in a concise way, etc. All right, one of these courses is usually required, sociology or cultural anthropology or a psychology course. So usually just one of those. What you'll need to do is when you find a program that you want to go to, you look up their prerequisites and make sure that you have checked all the boxes. Some of the exams or modalities will have different prerequisites required that are not listed here. So make sure you check that list from wherever you want to go to make sure that you've done all of them. All right, organizations, there's a whole bunch of different organizations that you will be able to be credentialed by. The oldest one is the ARRT because it is the oldest profession. And you can see by all these initials here that there are a lot of things that you can do within the ARRT realm. Bone density, you know, there's a lot. So quality management, therapy, radiology, radiologist assistant, sonography, vascular interventional, vascular sonography, tons of information here. So ARDMS is also another one. So that's the American Registry of Diagnostic Medical Sonography. There are several pathways in there, and each one of these will have a specific subcategory. So for example, your RDMS, so that's their medical diagnostic, so registered diagnostic medical sonographer. You can have a abdomen credential, you can have an OBGYN, small parts, breast, musculoskeletal has its own. So there's a lot of subcategories within the sonography world. The ARMRIT. So that's the American Registry of Magnetic Resonance Imaging Technologists. So that's for your MR. So for MRI, you can go through this organization, or you can be ARRT and do an MR up here. So there's multiple ways to get to where you want. CCI, Cardiac Credentialing International, has several pathways through it. So that's the RCES, which is Electrophysiology, RCIS, which is Cardiac Interventional, and the CRAT, which is the Rhythm Analyzer. So they diagnose or help monitor the EKGs. So that would be your EKG monitor tech. The IBHRE, so International Board of Heart Rhythm Examiners, gives you the CEPS after you take their test. And the CCI, the RCES, works with diagnostic and treatment options and implantation of cardiac devices, which we'll go into later. But the CEPS is basically dealing with the programming and functions of those cardiac devices. Last but not least, since we're in alphabetical order here, your Nuclear Medicine Technology Certification Board. So you have the Certified Nuclear Medicine Technologist. And if you look up here, you have the ARTN, which is the same thing. Most people will do both of those credentials since they're so similar. We need to talk about primary pathways and secondary pathways. So a primary pathway is an entry-level job in which you don't have to learn anything else besides your prerequisites. You don't have to be credentialed in any other modality before you enter into that. And there's several of these that we'll be talking about as we move through the rest of the presentation. Secondary pathway, that is a pathway in which, or a modality, in which you have to have a primary pathway first. So for example, radiography is a primary pathway. You can take your prerequisites, go to a X-ray school, and earn your ARRTR. Mammo, you have to have your ARRTR for radiographer before you move into mammography. All right, so that's the difference between primary and secondary. And I'll note the primary ones as we move through. So radiology, first and foremost, we'll talk about. There's 300,000 of us out there or more. So primary pathway, you can go straight into X-ray after finishing a radiology program. So you're called a radiographer, a radiologic technologist, or X-ray tech. So rad tech or X-ray tech is the most common nomenclature used. So you are primarily doing diagnostic procedures and you do some interventional procedures. So most people think about the skeletal X-rays. So you're taking a look at broken bones, but using a fluoroscope, which is a movie of X-rays, right? So instead of doing one stagnant picture or image of a body part, you take a series of images and record those, and you can see the physiological movement of whatever structure we are looking at. So for example, your GI, your gastrointestinal tract, will put in, have you swallow either iodine or barium, and we will view that as it moves through your GI system. The GU, so that's the genitals and the urinary system. So we'll take a look at those as well. You will find us in the ER. We have a strong presence there. Of course, the medical imaging department, the OR. So they have the fluoroscopes or stagnant, not stagnant, but static X-rays that you can take there. And anywhere a patient is found residing in a hospital, so the nursing unit. So we can take a portable unit and move that to the patient if they are too unstable to come down to us. We'll have, of course, an imaging department with a large unit that's very powerful, more powerful in energy than the portable one, because it has room to have a larger generator. So we'd like to do a lot of the images in our rooms because they're specifically designed and have specific parameters that make imaging better. But if the patient's too sick, we go to them. Sometimes there are limitations on what we can do portably, but you would learn that as you go along. So you'll find us in hospitals, in outpatient clinics. You can be a travel tech. So that means that after you usually take 2 years, and then you'll be able to go remotely and move throughout the country to where X-ray techs are not plentiful. So if there is a hospital that has a shortage, they can't find anybody that lives there, they'll have a travel tech company have a contract for usually about 13 weeks, and you move to that area, you do the imaging for that contract. The travel tech company pays for your housing, and you do the imaging there. You can either renew that once it's done or move back to wherever your home base is, or move to a different area. There's also mobile X-ray where you can take the X-ray machine and go to nursing homes or wherever the patient might be outside of a hospital environment. For example, you don't want to move a nursing home patient to the ER or the hospital just to take a chest X-ray. So they will hire someone to come take that chest X-ray right in their hospital bed in the nursing unit. And that saves a lot of hassle and expense for moving a patient just for a less than 5-minute exam. All right, so that's the mobile X-ray. Radiation therapy is another primary pathway. You can go through and be an ARRT for therapy. You work closely with the oncologist, so you are helping treat cancer patients. and you work with the dosimetrist in order to shape whatever beam of radiation you are interacting with the patient with. So you limit the damage, because the whole point of radiation therapy is to kill the cancer cells. So you want to kill the cancer cells and limit the destruction of the normal tissue around it. So the dosimetrist and the radiation therapist work together to make sure that that beam, whatever beam shape, is calibrated to each patient, and it goes in the right direction and the right angle to limit the damage. So you are doing therapeutic interventions with cancer patients. You can use either radiation that has a higher energy level that's used in diagnostic radiology. So diagnostic radiology has a certain energy level that we use to go through the body to get the image. Now the radiation therapist will use a higher one to kill those cells, as opposed to just pass through and get an image. So it's a higher radiation dose, but it is shaped to a narrow area to limit the damage. You can also use particle beams. So you have a accelerator that uses particles, and you shoot the cancer cells with that particle beam and deposit that energy into the cancer cells that you're trying to kill. And that limits the damage to the tissues before and after that cancer cell as it travels through the body. You'll find these professionals in hospitals and clinics. Nuclear medicine is a primary pathway. So they are called nuclear medicine technologists, nuke med tech, or an NM tech for short. There are two organizations that provide credentialing for this profession. It's the ART, and that's the NM, so nuclear medicine, or the Nuke Med board, and you get a CNMT, so that's Certified Nuclear Medicine Technologist. You deal with radioisotopes, especially designed to interact with certain cells within the body. So you can take a look at the cardiomyocytes and see if the person has stroke. They can take a look at viability of the tissue, etc. You can take a look at bones to look for cancers in that system. Solid organs, GI issues, pulmonary. There's a variety of imaging modalities or imaging that you can do for each of the anatomical systems within the body. Another thing that you can do within nuclear medicine, you can specialize into PET or PET CT. So positron emission tomography is another area of nuke med. And you can take a PET scanner and build it alongside or with a CT scanner. So you're scanning the person and getting both the high resolution CT scans and images, and you get the physiological data from the PET. And since it's one image obtained at the same time, those fuse together and you get a perfect overlap of where things are happening within that body. If it's an abnormality, it's excellent. You get a high resolution picture of that structure, as well as the highlighting with the positron emission. You'll find that in hospital imaging departments, clinics, and PET you can still see in certain areas that people don't have a PET machine in their hospital. They're quite expensive. You'll have them in the semi-trailer tractors, the vans, that's the enclosed trailer for a semi-truck. So you'll find travel techs for nuke med that go around to different hospitals that need them on a scheduled basis. Sonography is a primary pathway. You can get it through the ART, so sonography or vascular sonography, but the vast majority of people go through the ARDMS, so that's the American Registry of Diagnostic Medical Sonography. And these are the main categories, so you can be a diagnostic medical sonographer, diagnostic cardiac sonographer, that's the echo tech, Vascular technology or technologist, it's RBT. And musculoskeletal is a relatively new one, as well as a midwife. You can become a sonographer through being a midwife first, and they have a specific perinatal or fetal certificate for this profession. Uses sound waves. So sound waves are produced in a crystal in a transducer. That transducer is held up against the body. It has some gel on it to make sure that the sound wave goes from the crystal to the body. That sound wave interacts with the tissue and bounces back to the transducer. The computer calculates the time that happened and produces an image. All body systems can be imaged in this. A lot of times people think of only the fetal images, but it can do so much more than that. You can take a look at the brain tissue to see viability within the brain. You can take a look at the heart, the skeletals, so joints. It doesn't do well with lungs, but pretty much everywhere else is a really good imaging modality. A lot of people like it since it doesn't have any ionizing radiation, which is the problem with your x-rays and the physics behind that. All right, you can find them in hospitals, ER, nursing units, imaging departments, clinics, anywhere a patient is within the hospital, ultrasound can go. OR sometimes, usually not, but for the techs, they'll have ultrasound units that are run by physicians in the OR, but you can consult. I know of ultrasonographers that go in and help with vascular studies in the OR. So a vast array of imaging locations for this profession. The cardiac electrophysiology specialist is a primary pathway, but not through the ART. If you want to go through the, well, ART does not have a credential for this. So you can enter into this from being no medical background, except for your prerequisites, or you can transfer in, you can be an x-ray tech, you can be a nurse, you can be an EMT, you can be a medical assistant, any profession that you can think of, you can cross over and go through a program. I'm the director of this program, so if you are interested in this one, let me know. So that's the RCES, that's a registered cardiac electrophysiology specialist. And that's through the CCI, which is Cardiac Credentialing International. There are 3 main things that you do. The diagnosis and treatment of cardiac arrhythmias, and then the implantation or assisting with the implantation of cardiac devices. So in the first 2, you are looking for the reason why the person has a cardiac arrhythmia. So say, for example, they have atrial fib or AFib. It's a common ailment, unfortunately. So if you have AFib that cannot be managed by medicine or lifestyle changes, you need to find out the cause of the AFib. We find it, that's the diagnosis, and then we treat it. So we take a specialized catheter and you introduce that into the heart to where the bad cells are. It has a metal tip. We use radio waves and we heat that tip up, which burns those cardiac cells that are conducting abnormally. When they are dead, they no longer can conduct the abnormal rhythm, and the normal rhythm is usually restored quite instantaneously. Okay, so that's a really good thing to do when you have a potentially lethal rhythm. So we deal with all rhythms, from fairly benign to very serious, and we can correct any of those. So with certain parameters, you're looking at the heart, you can stimulate the heart at a certain rate, so you physically can take over the heartbeat and say, I want it to beat at 100 beats per minute. I want it to beat for 60. I want it to beat for 200 beats per minute. And you're controlling that, and you're seeing how the heart reacts to that stimuli to help elicit that bad conduction pathway or the abnormal pathway, so you can find it and then treat it. The last part that we talked about was the cardiac devices. So pacemakers and implantable cardiac defibrillators are put in on a routine basis. We do quite a few of those, and you are assisting the physician. So you have a cardiologist for this one. The first part, the detection and treatment, is the cardiac electrophysiologist, which is a cardiologist with additional training past their cardiology fellowship. So it's a long haul to get there. Very smart people. So you are helping that person. You are holding the cautery device. You're handing that off. The Wheatlander, the spreader for when you do the pocket. You hand them the lidocaine, all the instruments that you need to implant a cardiac device. Now, after you've done that for 2 years, after your RCES, you are able to sit for the CEPS, which sounds a lot alike, right? So it's a registered cardiac electrophysiology specialist, and then the advanced degree is cardiac electrophysiology specialist. Same words, right? So they took off the R and put the EP as instead of E on the RCES, right? The difference behind them really is the first one is you're assisting with implantation of devices. The second one is you're programming those devices. So you might have $50,000 to $100,000 worth of your company's product, so pacemakers and ICDs, in the trunk of your car, hidden so no one sees them. And you will drive around to different ORs in your region, however large that region is. And you will bring whatever model and type of pacemaker into the OR. And instead of standing by the physician, you're on the other side of the table with a programmer device that will, once the pacemaker is implanted by your RCES person, you now program that in conjunction with the physician. You collaborate with that and say, okay, we wanted to have a backup rhythm of 100. We want to have it sense in the atria or the ventricle. So you help program that device to make sure that when the patient is completely sewn up and leave the hospital, that device operates appropriately. All right. Hospitals and heart clinics. So most of the work in this profession is in the OR and the EP suites. An EP suite is a specialized OR suite. So you have the same sterile protocol and all of those things that you find in OR suite. It just has specialized equipment. You can work in physicians' offices, but that's a minority of the people in the profession. Most of us work in the hospitals. Okay, cardiovascular interventional radiology. So most people just call this IR, so interventional radiology. So it's cardiovascular, so it's dealing with the vascular system. It deals with all the vascular system except for the heart. You have to be an X-ray tech first. So this is a secondary pathway. And again, most people call it IR. So the degree or credential that you will have is ARRT, and then in parentheses, you'll have VI, so vascular interventional. The people in this profession use fluoroscopy and ultrasound. Interesting note, fluoroscopy, which is the real-time viewing, was invented by Thomas Edison a few years after X-rays were discovered. So fluoroscopy has been around for a long time, and it keeps getting better. Less radiation is used. The images are magnified better. The first one, you had the person looking into the direct beam because we didn't know. So quite a few of those earlier practitioners got cataracts in their eye. That no longer happens because of the way we have the safety built in. So how safe are these professions using X-rays? Extremely safe as long as you follow your proper procedures. So you don't want to be standing behind the patient and have the x-rays hit you. You stand behind a lead wall because we do so many x-rays, we can't be in the room with the patient because x-ray dose is cumulative. It builds up over time. So we go behind the wall because we are exposed. You have the potential to be exposed to dangerous levels. We go behind the wall. The lead stops that x-ray from hitting us. And there are only issues if you ignore safety on purpose. So safe jobs. All right. We can do all body parts within the human body. Neuro, we can do vascular, we can do solid organs, we can put in catheters. There are just a plethora of things that you can do here. One of the hardest parts of this job is the vast quantity of exam types and the equipment you use to do each procedure. I teach this program, so there's ways to cut down the volume of stuff you have to memorize. And if you go through this program through me, I will help you guide through that process of getting that information down. All right, you can also do biopsies in interventional radiology. Hospitals and surgical clinics. So you have to have a backup in most cases to do surgery if your procedure requires it. So you do your procedure and it becomes more invasive than what was planned. You have to have a surgical team as a backup to make sure that the patient is safe in that more extreme setting. Cardiac interventional. All right, so this is interventional radiology as well, as opposed to cardiac vascular. This is cardiac interventional. So here you're dealing with the heart. Now the heart's a very straightforward organ, right? But it has a lot of things that can go wrong with it. And these are the specialists that assist the cardiologist in fixing those. So you can do diagnostic procedures to see what's going wrong. And if your credentialing allows it, the hospital, you can go in and fix it. So there's two types of labs. There's the diagnostic only, and then there's the interventional lab. So the diagnostic only can go in and look at the vascular system. So these are the plumbers of the heart. The EP techs are the electricians, and these guys are the plumbers. So they can look at the plumbing, the vascular system, but if they see something wrong, they have to transfer the patient to an interventional lab in order to do the interventional procedure because they're not licensed. They usually is because they don't have a dedicated cardiac thoracic surgery team on site at all times or on call. So the interventional labs have a addition of the cardiac surgery backup in case something goes drastically wrong. It's very rare, but it can happen. So in case of those can happens, we have that backup. All right, so there's the cardiac cath lab, that is the ART-CI, so cardiac interventional, or a secondary pathway. You don't have to be an X-ray tech to work in the cardiac cath lab. Quite a few hospitals have what's called the registered cardiac interventional specialist. They're not an X-ray tech, but they have specialized training for everything in the cath lab. So they're very knowledgeable people, but in some states, they cannot touch the fluoral unit. For example, in California, they are unable to move the fluoral unit because California needs a specific license to do that. So I don't know if you noticed on my credentials at the beginning, I have CRT parentheses F. So that F means that I am able to move a fluoral machine in the state of California. And CRT means that I can work in the state of California. Yeah, so good profession, good people. Just there's some limitations in certain states. All right, they focus on the vessels. So I wanted to say valves and vessels at the same time, so that came out as vessels. So the valves and the vessels of the heart are the primary focus. They also, of course, take a look at the chamber size, heart wall motion. So there's a lot of things going on in the cardiac cath lab. If you see a stenosis, so one of the vessels of one of the coronaries, vessel of the heart, is narrowed, they can go in and take a balloon and deliver that balloon to that area and expand the balloon. And that will expand the vessel walls out and return that normal lumen, or the empty hole, the space that's filled with blood, increase that size and return normal function to that body part. Because if it gets too ischemic and closes off or occludes, the cells that were depending on that refreshing oxygen through every beat, those cells will become ischemic and then die. So we want to go in there and do a PCI, percutaneous cardiovascular intervention, and open those vessels back up to normal lumen size. And once that is done, the ischemic changes go away. You have to catch them before they die. Once they're dead, the tissue doesn't really regenerate, so that will be a cardiovascular accident there, or a stroke. Okay, so you can cross over into electrophysiology in some labs. But normally people want you to have specific EP training to go into EP. You'll see these professionals in hospitals, and those will be, or surgery hospitals as well. So nearby my location, there is a cardiac surgery hospital. So it's not a full hospital, doesn't have nursing units. It has a recovery unit, and people go in there, have interventional procedures. They have a backup. So you can do that kind of a thing if you have the proper facility. But mostly it's in hospitals. So OR suites or cath lab suites. Okay. CT, secondary pathway, must be a rad tech or nuclear medicine tech first. So the nuke med tech will take the ART. So, and then the rad tech will take the ART, and they will earn the ARRT CT. And of course, they'll have an R before their name, before CT. Okay, nuclear medicine goes through the same credentials and can do CT as well. So computed tomography. So that is X-ray images. So the X-ray, instead of being stationary in one spot, it moves around the patient, and a computer generates an algorithm and generates a high resolution image. So you can take a look at the anatomy. You can take a look at any body system basically. And because of that, it's very versatile. It used to be called computed axial tomography, so CAT, CAT scan. We dropped the A because we can reconstruct in more planes than just axial, going head to foot. We can do sagittal, left to right, and coronal, anterior to posterior. So because of those other exams that we can do, they dropped the A, so now it's just CT instead of CAT. All body systems perform interventional procedures, so you can do biopsies with CT guidance and other drainages. There's quite a few things that you can do in the CT suite if you can't do it in the IR suite, the interventional radiology. So those two staff work together quite well. So you can work in CT and work in IR, and then if you need to do CT, you go from your IR suite, you take the patient to the CT, and you can do the exam there, or have your CT techs do it. Again, lots of options. All right, you find these in hospitals. In most hospitals, especially the large ones, they try to put the CT as close to ER as possible, if not in the ER. So a lot of the newer ERs will have one or two CTs depending on the volume of the ER patient. How many people come per day? You might get 2 CT scanners directly in the ER, because it does seem that CT is used a lot in that department. Imaging department, of course, outpatient clinics are other ones. There are portable CTs, but those are very rare, and they're, in my humble opinion, the quality of a portable CT doesn't match a one that has a whole suite with it. But other people might have varying opinions on that, and that's okay. Magnetic resonance imaging is a primary pathway. Most people will go ARTR, so they're the radiographer first, and then go into MR. Most employers, judging by job posting, so that's my data that holds up this. Most facilities will want you to be an X-ray tech and do MR as well. So the second pathway is through the ARMRIT. So you don't have to be an X-ray tech first. But again, based on job posting, the majority of employers want your ARTR than MR. But there are enough employers that hire the American Registry of Magnetic Resonance Imaging Technologists that it's still a viable pathway. I'm not putting anyone down. I'm just looking at data. Okay, so again, very professional people. It's just two ways to get there. Okay. Use a very strong magnet. The Earth's magnetic field is 0.5 Gauss, and the magnet, a 1 Tesla magnet, is 10,000 Gauss. So that's 20,000 times stronger than the Earth's magnetic field, which is a very big deal. So you have to be very sure that the patient doesn't have any metal that will interact with the magnet. So that's ferromagnetic metal in there. So iron, cobalt, and nickel are all ferromagnetic. So when they're introduced into a magnet, they can become magnetized, and they have a strong attraction to the magnet. So if you have a aneurysm clip in the brain, for example, that is made of stainless steel, that iron in that clip can interact with the magnet. So when you're going in, that aneurysm clip is around a blood vessel that was had an aneurysm in it. You clipped it so you are strengthening that wall with that metal. And as you move in, you're moving through the different flux lines of that magnet. And because of that, it can react and turn. And when it turns like that, you could clip that blood vessel, and now you have a brain bleed that's active, and the patient can die. So you have to make sure that you are following all safety procedures when you're working in that type of environment. You have 3 Tesla magnets, so that's 60,000 times the Earth's magnetic field. So you have to make sure you don't allow anyone with scissors, for example. You have stainless steel scissors that you use to remove dressings, and nurses do that. Variety of reasons for that, you have these scissors with you. So if you walk in there with the scissors can be attracted to the magnet and be pulled out of, if you're holding it, or if it's in your pocket, get removed from your person and fly into the magnet. And if you have a patient in that magnet, you could have a very bad ending. So you have to be safety conscious to work in MRI. I started working in MRI in 1997. So I have quite a few years of that. I get to teach MRI physics, which is a lot of fun. All right. Hospitals, clinics, and mobile units. So you can find your magnetic resonance imaging units in a semi-trailer, if the place does that. But that's more of a rarity now. Well, I know of a hospital that has a permanent trailer on that they purchased, and it's a trailer so the hospital and the outpatients both go out to the outside and go up and onto a lift into that magnet. It's because the hospital was made and did not have an MRI magnet, and because of construction constraints or capital revenue, whatever reason, it's more effective to have a trailer as opposed to trying to find a location to put a new magnet in the existing hospital. So there's a variety of things that you can do there. Again, hospitals, Outpatient clinics have them, mobile units. And there's a variety of strengths of magnets too. Claustrophobic people that are afraid of small places, you might want to have an open MRI. Open MRIs have a weaker magnet style, so the images aren't as good, but a slightly less good image is better than no image at all. So that's why those exist. Mammo. All right, so you have to be an X-ray tech first. So you have to have your ART-R before you earn your M. All right, mammographer, mammotech are the most common nomenclature. Uses special X-rays. So we talked about X-rays being at a certain energy level to pass through the body to get the image. Therapy is a higher level to pass through and stop and kill the cancer cells. But mammo, for specific reasons that you would learn when you go through a program, uses a softer X-ray. So it is less energy because of the natural or inherent contrast of the tissue types, fiber and fat in a breast. Okay, so it uses a special tube, special physics that you'd learn when you go through this. So you can do diagnostic screening, and you can do guided biopsies using the mammo machine that you put in and take a sample. Hospitals, outpatient clinics, and there are some mobile units that go around to areas that don't have any mammo, and will do a day of mammo in a certain area. So a variety of locations for this profession. Bone density uses X-rays at a specific energy level again, just like X-rays, therapy, mammo. Bone density also has a specific physics behind it, which you would learn. You earn the BD, bone density, from the ART. And hospitals and clinics are their working locations as well. Registered radiologist assistant. So the radiologist is a physician with one of the longest fellowships and residency in the medical profession. So here you are getting advanced training to assist the radiologist in performing some of those invasive procedures. So lumbar punctures, you do the fluoro instead of the radiologist doing the fluoro. You can do it, and you are looking for a specific pathology. You are, now it is confusing. Before radiologist assistant came along, it's akin to a PA, a physician assistant, but it's specifically designed for people working in the radiology department. So you have to be an X-ray tech first. You have to have a certain number of years to enter the program. So you have that experience of watching it first, then before you do it, right? Now the other term was radiology assistant. So the radiology assistant isn't an X-ray tech, it's the transporter. So they help with patient transport, non-tech patient flow. Maybe they'll help change the patient to get them ready for the procedure. So they're very close. So radiologist assistant is an advanced profession, whereas the radiology assistant, a lot of them actually go in and take X-ray and become an X-ray tech. I know that one of the transporters I used to work with, we would have him watch the procedures, patient confidential. They're okay to watch the patient, right? So we're following all rules, but he learned that he wanted to be an X-ray tech, and then he went through the X-ray program, and with that knowledge of how to move patients, how to interact with patients, he moved fairly seamlessly into being an X-ray tech, doing exams, and providing that care that an X-ray tech will. All right, so the radiologist assists in the performance of diagnostic and interventional procedures that a X-ray tech would not be able to do. All right, and that's hospitals mainly. All VA hospitals in the entire nation will accept and hire radiologist assistants. And there are currently 13 states that hire them. You can train for it in any state, but 13 states right now are able to work as an RRA. All right, we are working on legislation to make it national. Echocardiography, we touched briefly on this. It is using sound waves, just like a ultrasonographer, but this is specifically for the heart. So you're taking still images and cine images. So cine echocardiography is just like, it's like fluoro, but using the ultrasound waves instead, right? So you get a real-time movie of whatever the operator is looking at. They're called echocardiographer or echotech. You work through the ARDMS to get this certification. Uses sound waves to create the images, movies, or static images. Hospitals and outpatient clinics are the majority of places where you will find employment in this profession. Management. So management, there are numerous ways to get there. It depends on what level of management you are. So supervisors and managers usually are required to be ARRT and or some of the other modalities that we've talked about. So they have to have imaging experience because they are the front line. So the supervisor is usually an AS, sometimes BS degree. Manager is usually a BS degree and ART only. For example, when I became a manager, I had an associate degree. But if I wanted to move to a director, I had to finish my bachelor degree. Once I finished my bachelor degree, they promoted me from manager to imaging director. So director is usually a master's now. So when I was a director, an area director, it was normal to have a bachelor degree. But as we move down the line, the higher up you go, the more degrees you need, because it is more global position. So you can get your master's in a variety of settings. You can get the MBA. A lot of sites will say in their ad, right down here, job postings, MBA or equivalent. So equivalent is your Master's of Science in Radiation Sciences. So that is an equivalent. This is what I have my master's in. It takes quite a few of the business administration factors, but it focuses it on the direct management of a imaging department. So that's that. You can get a master's in education or administration. Those are the master's qualifications. Okay, the area director or systems director, you have more than one facility underneath you, a master's degree is required for those. Okay, all right, hospitals and clinics. So an area director will take care of 2 hospitals or more. A system director might be over a dozen of the imaging departments, and they'll have a director or manager underneath them at the site so that they will do remote calling through their region and oversee those system goals. So you're more in charge of finance and staffing, direction of the department on how you want to go. You're looking at trends and figures. When you get to that level, you rarely do imaging. It's mostly clerical. Well, not clerical, but administrative roles where you are defining practice, writing protocols. I was an area director. I had 2 hospitals and 2 outpatient clinics, 112 staff. So I needed to know what my staff were doing, if they were doing overtime. I've worked on equipment acquisition. Buying and implementing a CT scanner has a lot of things involved. You have to find the funding for it. You talk with the senior management, make sure that you get the funding. You can get some grants if you're creative. There's a lot of things that are involved in doing that. You have to have a medical health physicist come and measure the stopping quality or attenuation value of your walls to make sure that the new scanner won't allow too much radiation to pass through the walls and go through into a hallway that is occupied by the public and others. You have to arrange, if you only have one scanner, you have to have a backup scanner and train people on that to make sure that you have continuity of care. So there's a lot of things that go on behind the scenes for your management, and you learn those theories in your master's programs. All right. Education. So I went through management and education because those are my two roles that I've done for many years. I've done both of them at the same time. So I wanted to make sure that I was up to date on current methodologies of teaching. You have to be one of the credentialed pathways in order to educate people in medical imaging, right? And preferably credentialed in the modality that you are teaching. For example, I've taught X-ray physics because I'm an X-ray tech. I've taught CT physics because I'm a CT tech, and I've taught MRI physics because I'm an MRI tech, right? I've taught management because I was a director. So you want to have someone with that experience. One of the biggest things in teaching is not just relaying information, but how does the information and material that you're talking about, how does that relate in real life to what you want to do and what you're going to see? So you have to have a strong clinical background. So you can say, oh, well, you know, this is how this works, and you might see it in this situation, and watch out for this pitfall that you might experience. You have to have that clinical background in order to know how and what to teach in the educational section. So most places now are requiring a bachelor's for teaching. So if you want to be an instructor, you're going to have a bachelor's. If you want to be a program director, I had to have a master's degree to become a program director. So my master's degree, I did both in administration and education, so I can cover both areas. Now, if you want to go higher up, you have to have a doctorate of some sort. So usually, and it doesn't matter what the doctorate is, usually it says, you know, doctorate of education or equivalent again. So you have some flexibility, but you want to take a look at job postings to make sure that you're getting the degree that you want for whatever position you are looking for. PACS administration. So for the first 110, 115 years of radiology, we had glass plates that we took pictures on. We took pictures on cellulose-based flexible camera film that were 14 by 17 inches across, or 8 by 10, and various sizes in between those. Now, everything is done digitally. So you have to have a digital archive and access point for all these digital images. And that is where the PACS administrator comes in. So the PACS administrator is a blend of clinical and IT backgrounds. So I've worked with people with clinical backgrounds that became a PACS administrator. I became a PACS administrator, so I get to teach that as well. But you can have an IT background and learn about the clinical, or you be a clinical and learn about IT. So you can have either one. And I've worked with both types of professionals, and I've had experience with good PACS administrators from both. And unfortunately, I've had ones that are little lax in what they need to do from both backgrounds. So it really depends on the training and the person, how well that does. You want to have the PACS up and running. That's the archive. So the physicians and nursing and respiratory therapy, anybody that needs to look at that image can have that image on demand. If your PACS goes down because you forgot to back it up, that's your fault, and that impacts patient care throughout the organization. So every nursing unit, the OR, ER, anywhere there's patients that have images that people want to look at, if your PAC system goes down, you're getting a phone call within seconds saying, my PACS isn't working, you need to fix it. So you want to make sure you're proactive in this job. Another part of it is troubleshooting. You know, if you have a person that can't use it, you need to figure out why. Is it that computer? Is it a network switch? Is it the mainframe that you're working on? What level of error are you trying to find? So you have to quickly figure out where the errors are and where they aren't. So if you know the structure of your PACS, you can right away say, okay, well, this machine isn't working, but this one is. So it's not this problem, it's the problem over here. So you can define where that problem is by knowing the architecture and the network that your machines are joined to, and right away figure out the problem. So you could either fix it, or if it's a little more than what you know how to do, you call PAC service and say, I'm having a problem at XYZ. And then they don't have to search where it is. You've already told them where it is, and they can go right to the problem and fix it. It's very important to know what you're doing. Maintenance of the system is important, and a lot of education of users, the people that are going to be viewing it. So the physicians, the respiratory therapists take a look to make sure they know where the placement of their ET tubes are, et cetera. Anywhere there's medical imaging, there should be a PACS administrator in the background. This is one of the jobs that you are only noticed if you do something wrong. So you don't want to be noticed because you want to have it smooth. All right. Multiple modalities. You can mix and match the majority of these things. Common pairings are X-ray tech, CT, and MR, or just rad tech and CT, or rad tech and MR, but a lot of places will hire you to do all three, right? PET CT is a very common matching or pairing. Rad tech and ultrasound, a little less. Usually it's you either are an ultrasound tech or you're a rad tech. Very few places that I know of have that combination. One of my employees at one of my directorships was a rad tech ultrasound. So that was very beneficial for staffing. And being a multi-modality tech does help get you a job faster, because the management sees that you can work in multiple areas. So if someone calls in sick, they can transfer you from one area to the other. And since you know how to do it, it's no big deal. You just go over and take care of patients in a different modality. All right, so anything goes. There are more common pairings, but you know, you can do multiple things like bone density, mammo for the ladies, et cetera. All right, so for me, what I did was I became an X-ray tech. Then I learned CT and MR, went through a program. Cardiac cath lab and interventional radiology, I was able to pick up. I got trained as a PACS administrator. I went through management, so I worked from supervisor to area director. I've been an educator for a really long time, and I went back to school for a second profession. So I went back for cardiac electrophysiology, and I'm the director of that one. And I get to teach in CT, MR, cardiac cath lab, interventional radiology, PACS, management. So I get to teach in all that stuff now, which is really fun. I like the variety. Now, there are different pathways for different people. My wife and I met in X-ray school, so she's an X-ray tech. I went the CT-MR and the other modality route, and she went through ultrasound and echo. So she has all the ultrasound modalities down as credentialed in those. And she can also do echo. Now, she did echo and she liked ultrasound better. So she is qualified to do echo, but she does mainly just ultrasound. She's still an X-ray tech, and technically could do x-ray, but she really hasn't done any x-rays in 20 years because she's focused on ultrasound. Now, if we were to move to a small area that had a fewer techs, she's still licensed, could pick that back up and do x-ray, just like me. If we wanted to go somewhere else that, I could do any of those things that I've learned and are credentialed in. So there's a lot of options in this field. I hope that you have been able to separate some of that jumbled mesh of all those modalities that we talked about. And there's one thing we need to talk about as well. So there are limited technicians. So a full technologist is what we've been talking about so far, but a technician is something a little different. So a technician is usually, the education is usually a couple of months, where an X-ray tech is 2 years with almost 2,000 hours of education. Limited technician will take a limited scope profession courses that cover just the spine or upper extremity, just the lower extremity, the abdomen, and then take tests to pass for taking x-rays of that body part. So for example, I had a limited technician working for me. They had the spine, they had the L spine, but they couldn't take a picture of the abdomen. So the L spine is in the back part of the abdomen. So they could take a picture of the L spine, but they couldn't open up and take a picture of the whole abdomen. They didn't have a license for that. So because of that, they do have limited areas where they can work. A lot of physicians, I know of an orthopedist that has a limited tech working for them that does hands. They're orthopedic surgeon of the hand, that's their specialty. So they hired a limited tech that does hands. So that limited tech does really good work for hands. So a lot of people I know that are limited techs, they're good people, but they do have limitations to their specialty. They can't do fluoro. They have no specialization. You can't do CT, you can't do MR, unless you go through the ARMRIT. It's a big alphabet soup here that we talk about all the time. So I have to make sure that I'm saying all the letters in the right order. So, and they can't do skull imaging, but that's not as big as a problem as it used to be, but because most of the skull injuries goes to CT and they can do CT reconstructions. You can take a look at the skull and the skull contents, the brain, to make sure there's not a bleed or a stroke. So a lot of the skull work that we X-ray techs used to do are really limited now. So that's not a huge limitation for a limited tech because there's not just a lot of skull work out there, skull imaging, other than CT. Now, MRI isn't really good for bone. It is better for the soft tissue. So we do a lot of brain imaging in MRI, just like CT for car accidents and whatnot. And each one has their strengths and weaknesses on what each one can do. All right, so that is my information session today. I put in all the things that we talked about earlier and highlighted the primary ones. So you can pause this one if you'd like. Everything's on the same page. All those little abbreviations are explained here. And I hope you enjoyed this presentation. And I will be making some more to put on my YouTube channel. And hope you have a great day. Thanks.